Kirakoto, my name is Jesse. I'm the anesthetic technician in New Zealand, and I'm working in one of the hospital in New Zealand. So continue with the crisis management. The topic today is called local anesthetic toxicity. So as you know that we work in the anesthetic field, so we give a lot of local anesthetic to the patients, and but we never know. Sometimes we give the dose, a wrong dose to the patient, and the patient get the toxicity or from the anesthetic medications. So with this situation, what are you going to do first? And then further investigation and then the treatment for the anesthetic toxicity. And in this video, I will mention the crisis management card. What are you going to do first? And like I mentioned earlier in the previous video, all the material on resources in this video come from one of the hospital in New Zealand as I work. And you never know, one day you come to New Zealand and you will, if you watch my video, you get familiar with the emergency situations. And I hope one day I will see you in New Zealand. To be a technician in New Zealand is a great honor. It's very good for me, and I love it. And I think one day if you come to New Zealand, you feel the same. You won't stay in New Zealand for long and to work in the anesthetic field. Okay, now I will show you the crisis management card. Right, if we recognize the sign and symptom of local anesthetic toxicity, the main priorities, good qualities, CPI and early interlipid. Stop administration of local anesthetics and get a local anesthetic toxicity box. So each hospital we have the local anesthetic toxicity box, and you have to know where it is, and then in this case you have to come and take it straight away. In this case, you can ask a nurse. They can help you again, because when you put the emergency belt, a lot of people will turn up and they will give you a hand. If size of cardiac output, consider need for intubations. Ventilate if required. Aim for ETCO2 30, around 30. Confirm IV access. If arrhythmia, use standard protocols. Support mean arterial pressures with fluid and vascular pressures. Treat seizures, midazolam IV 2 to 7 mg if refractory intubate. Consider giving IV 20% interlipid. If cardiac arrest, start CPR. Be prepared to continue for 60 minutes. Mobilize cardiopulmonary bypass, ECMO team if available. Give 20% IV interlipid. Bolus 100 ml. Can repeat every 5 minutes, maximum twice if required. Infusion 1000 ml per hour need interlipid. Double right at 5 minutes if no improvement. Do not access the maximum dose of 840 ml. Sense arterial blood gas. Keep pH above 7.25. Give sodium bicarbonate 8.4%, 50 ml. Can repeat every 2 minutes. Must ensure adequate ventilation. That's what we do with the patient. We have the local anesthetic toxicity. First thing we have to do is stop the local anesthetics and contact the team. Like you have to make sure that you push the belt and then call for help. So the team will interlipid is main things that we treat for the anesthetic toxicities. So for one at hospital I work, we have to contact the ICUs to get the interlipid. So it depends on your hospital where you keep the interlipid, and then we follow the protocol here to treat for the local anesthetic toxicity. Now for the further the sign and symptom of local anesthetic, so you can toxicity, so you can recognize when you come up with the case like it. Sign of local anesthetic toxicities. For first thing we go for the central nervous system. Patient will feel numbed tongues, tinnitus, metabolic taste, slur speech, seizures, and unconscious. Cardiovascular decrease, mean arterial pressures, QRS, bradycardia deteriorating into PAs and asystolic. Temporary patients may be required for symptomatic bradycardia. So that is the symptom that you normally ask the patient, like if you feel anything like around your tongue or any metabolic something like that. Right, pediatric dosage, midazolam IV 0.15 milligram per kg, IM 0.2 milligram per kg, buccal 0.5 milligram per kg can repeat at 5 minutes. Intralipid 20%, bolus 1.5 ml per kg can repeat every 5 minutes. Time 2, infusion 15 milligram per kg per hour, at least 5 minutes can double rate if no improvement. Max accumulative dose equal 12 ml per kg. This is the dose for the pediatric. The dose for the adult we already mentioned at the first things of the crisis management car. All right. Thank you for watching my video, and you know that it's very rare, but you never know, in the future you're going to come up with a patient have a local anesthetic toxicity, and then the crisis management guide is very useful. So sometimes if we have time we have to review it, otherwise we will forget. And for me, like, we always follow ABCD, airways, breathing, and circulation. Make sure the patient in a good the oral numbers in a normal range. um, Intralipid is the main thing to rescue the patient with the local anesthetic toxicity, and make sure that you don't confuse with the propofol. Okay, and that's it. Thank you for watching my video, and then the next I'll try to finish all the crisis management card and from my hospital, and it's good. Like I said, it's good learning material and resources for everybody, and hopefully you can share. You can take a photo and then put it on a comment, and in the video you can share with us, like, what are you gonna do, what are your protocol in your hospital if the patient have the local anesthetic toxicity. So what are your protocol, and then compare with us, so is there any different. So hopefully you can interact with my channel, so we can learn from each other. All right, thank you very much, and see you in the next video.